You took your pill this morning. You did not think twice about it. 10 seconds, maybe less. Same routine, same glass of water, same moment before breakfast, just like every morning since your doctor handed you that prescription. And if you are over 60 and that pill happens to be Amlodipine, Losartan, or Lisinopril, I want you to stay right here with me today. Because there is a very real chance something has been happening inside your body for months, possibly longer, and nobody ever sat down to explain it to you properly. Not because your doctor is hiding anything, not because the medication is wrong, but because a standard appointment gives a physician roughly 12 minutes. And what I am about to share with you genuinely deserves much longer than 12 minutes. My name is Dr. David Aid. I work in cardiovascular health and patient education, and today I want to walk you through the 9 most important things every senior on these 3 medications absolutely needs to understand. The 9th one, stay with me. I saved it for last because it changes everything. Before we go any further, I want to ask you something. Since you started your blood pressure medication, have you noticed any change in your body that you quietly filed away as, well, just getting older? A cough that showed up months after you started the pill and never quite left. Ankles that look fine in the morning but feel tight by evening. A little dizziness when you stand up too fast. Maybe a subtle change in your energy that you never connected to anything specific. If any of that sounds familiar, drop it in the comments right now. Tell me what you noticed and how long it has been happening. I read every one of those comments, and I want to tell you, what you write today may be the thing that finally gives someone else the language to describe what they have been living with in silence. Now, most seniors I speak with share a very similar memory of the day they were first put on a blood pressure medication. A short appointment. A number spoken across a desk. High blood pressure. Sometimes without much more context than that. Then a prescription. A note to come back in a few months. And a bottle that arrives in your hand before you have fully processed what just happened. Most people walk away from that appointment believing something that is almost true, but not entirely accurate. That the medication is fixing the problem. The truth is more precise than that. And understanding that precision, truly understanding it, is the difference between managing your health and simply taking a pill. So let us start at the very beginning. What are these 3 medications actually doing inside your body? Amlodipine, Losartan, and Lisinopril all lower blood pressure. That part is straightforward, but they reach the same destination through completely different roads. And those different roads matter, because they produce different effects, different side effects, and completely different warning signs. If you do not understand which road your medication is traveling, you will not understand what your body is trying to tell you when something changes. Let us look at each one. Amlodipine, the calcium channel blocker. Your artery walls are lined with smooth muscle. That muscle tightens and relaxes based on one key trigger, calcium entering the muscle cells. When calcium flows in, the artery narrows, pressure builds, and your blood pressure rises. Think of the artery wall as having small entry gates for calcium. Amlodipine's job is to reduce how many of those gates are open at any given time. Less calcium getting through means less tightening, which means lower pressure. Here is the important nuance, though. Amlodipine is managing the output of the system. It is not removing whatever caused those artery walls to become tighter than they should be in the first place. It is turning down the pressure, not dismantling the source of it. Lisinopril, the ACE inhibitor. Your body naturally produces a substance called angiotensin II. This substance does 2 things. It tightens your blood vessels, and it signals your kidneys to hold on to more fluid, which also raises pressure. To produce angiotensin II, your body needs an enzyme, an ACE, angiotensin-converting enzyme. Lisinopril blocks that enzyme. No enzyme, no angiotensin II production. Think of it as shutting down the factory that makes the tightening signal. Because it also reduces the workload your kidneys are under, Lisinopril is often the preferred choice for seniors managing both blood pressure and early kidney concerns. One medication with 2 protective directions, Losartan, the ARB, or angiotensin receptor blocker. Losartan works on the same angiotensin II system as Lisinopril, but at a different point in the process. Instead of blocking the factory from producing the signal, Losartan lets the signal be made, but locks the door it needs to pass through to have its effect. The message gets sent. The door stays shut. The vessel never receives the instruction to tighten. Now, Here is a critical difference that every patient deserves to know. Lisinopril causes a dry, persistent cough in a significant number of people who take it. Losartan does not. This is one of the main reasons doctors switch patients from one to the other. Not because Losartan is more powerful, but because waking up at 2 in the morning with a tickling cough every single night is not something any senior should live with when a simple medication switch could resolve it. 3 medications. 3 entirely different mechanisms. The one you are on shapes what to watch for and what to report. I want to tell you about a man I will call Arthur. 76 years old, retired school principal, disciplined and proud of how carefully he had managed his health into his 70s. He had been on Amlodipine for blood pressure for 14 months. Not a single missed dose. One afternoon, I received a call from his wife. Her voice was quiet with worry. She told me he had stopped going to church. That his ankles, she said, she did not recognize his ankles anymore. Arthur had not had a heart attack. There was nothing acutely wrong with his heart. He had simply been living with swollen ankles for 3 months, convinced his heart was failing, skipping doses on the days he needed to walk because he was embarrassed by the way his legs looked in public. That silence almost cost him everything. Here is what Arthur needed to know from day one. Amlodipine relaxes the small arteries in your lower legs quite effectively, but it does not relax the small veins at the same rate. Blood flows down into your legs without much resistance. The return trip back up is slower. Fluid gradually shifts out of the vessels and into the surrounding tissue. That is why your shoes fit perfectly in the morning and feel tight by 6 in the evening. That is why the swelling retreats overnight when your legs are horizontal and returns by afternoon when you have been on your feet. It follows a predictable pattern because it is a predictable mechanical consequence of how this medication interacts with the vessels in your lower limbs. It is not heart failure. It is not kidney damage. It is not a sign that something terrible is silently unfolding. But here is what made Arthur's situation genuinely dangerous. It was not the swelling itself. It was the silence. He started quietly reducing his doses because he was embarrassed, and his blood pressure climbed without anyone knowing for 3 months. Skipping or reducing your blood pressure medication is far, far more dangerous than any swelling you have been sitting with. If you are on amlodipine and you have noticed swelling in your ankles or feet, especially swelling that is worse in the evening and better in the morning, report it to your doctor at your next appointment. Do not hide it. Do not quietly manage it by adjusting your doses on your own. There are real solutions available, and none of them require you to stop treating your blood pressure. If you are on Lisinopril, I need to ask you a direct question. Have you developed a cough since you started taking it? Not a wet cough, not a productive cough that brings anything up, a dry cough, scratchy, tickling, sitting at the back of your throat, the kind that nothing seems to clear. The critical thing about this cough, the thing that catches so many people completely off guard, is that it does not always start right away. Sometimes it appears weeks after beginning the medication, sometimes months. By the time it arrives, patients have completely stopped connecting it to their pill. They blame allergies. They blame reflux. They try lozenges. They change their laundry detergent. They check for mold in the house. And all the while, the answer has been sitting in their pill organizer every single morning. I am thinking of a woman I will call Patricia. 69 years old. 4 months after starting Lisinopril, she developed a persistent tickle in her throat that absolutely refused to leave. Sleepless nights, exhaustion from the constant urge to cough, trying everything. When I simply asked her when the cough began relative to her medication, she went completely quiet for a moment. Nobody had told her the Lisinopril cough can arrive late. A dry cough from Lisinopril is uncomfortable. It is not dangerous in itself, but it is also not something you have to accept. Report it. Ask whether switching to Losartan might be appropriate. You should not be lying awake coughing when there is an option available. However, there is one symptom that is in a completely different category. This one cannot wait. This one means stop what you are doing and get emergency care immediately. If you experience swelling of the lips, tongue, face, or throat while taking Lisinopril, especially if swallowing or breathing becomes difficult, that is a medical emergency. A CE inhibitors can in rare cases cause a condition called angioedema, and it can escalate to life-threatening within minutes. Dry cough, reported at your next appointment. Swelling of the face, lips, or throat, move now. Do not wait. Do not finish reading. Do not call the doctor's office and leave a message. Emergency care, immediately. I want you to think about your kitchen for a moment, not your medicine cabinet. Because one of the most underappreciated risks for seniors taking Losartan or Lisinopril is not in your pill organizer. It is sitting on your counter, possibly in something marketed specifically as heart healthy. Both Losartan and Lisinopril can raise potassium levels in your blood. Under normal circumstances with a balanced diet and stable kidney function, this is managed. But when potassium begins to climb too high, it affects the electrical rhythm of your heart, and the warning signs are not always dramatic. Muscle weakness, occasional cramping, a heartbeat that feels slightly off. Sometimes nothing noticeable at all until the levels are genuinely concerning. Now here is where the kitchen comes in. Many products marketed as heart-healthy or low sodium actually replace regular sodium chloride with potassium chloride. Salt substitutes, electrolyte powders, certain senior meal replacement drinks, sports recovery beverages. Every one of these quietly adds potassium to a body whose medication is already tending to retain it. I think of a man I will call Bernard, 74 years old on Losartan and doing all the right things, or so he thought. He had switched to a potassium-based salt substitute specifically because he read it was better for his heart. Nobody connected those two facts, the medication and the supplement. He began feeling weak and fatigued. His potassium came back dangerously elevated. Bernard was not careless. He was not uninformed in a general sense. He simply did not have this specific piece of information, that his medication and his heart-healthy salt substitute were working in the same direction at the same time. Read every label on every heart-healthy product in your kitchen, and ask your doctor or pharmacist this direct question. Given my current medication, is it safe for me to use a potassium-based salt substitute? That conversation is free, and it could prevent something serious that nobody saw coming because nobody thought to ask. After you finish this video, I want you to do one thing. Go to your bathroom cabinet and look for ibuprofen or naproxen. If you are taking Lisinopril or Losartan, especially if you are also on a diuretic, a water pill, regular use of these common over-the-counter pain relievers can reduce blood flow to the kidneys and increase the risk of kidney injury over time. Not because any single one of these medications is dangerous on its own, but because together, particularly in a body that is even slightly dehydrated, they create conditions the kidneys struggle to handle. And because ibuprofen comes from a pharmacy shelf without a prescription, it almost never gets mentioned in a doctor's appointment. It does not feel like a real medication in the way that a prescription does. Ask your pharmacist this exact question. Is it safe for me to use ibuprofen regularly, given all the medications I am currently on? That conversation takes 2 minutes, it costs nothing, and it may prevent a problem that no one was even watching for. There is one situation that trips up even the most careful and consistent patients. If you are on Losartan or Lisinopril and you get sick, a stomach virus, heavy vomiting, diarrhea, a fever with significant sweating, anything that depletes your body's fluid levels quickly, the medication that was calibrated perfectly for your body yesterday may behave very differently today. These medications were prescribed for a body with relatively stable fluid balance. When illness strips that away, the same dose can drop your blood pressure further than intended and place additional stress on your kidneys at exactly the moment they are already working hard. The medication did not become dangerous. The body it was working inside changed. A man I will call Gerald, 78 years old, 13 months without missing a single dose of his Losartan. He came down with a stomach virus, could not keep much down, but still took his medication every morning out of sheer discipline. That evening, he stood up from his chair and nearly collapsed. The problem was not his medication. His body was depleted. His blood pressure had dropped too far. Write this down and put it somewhere visible for days when you are unwell. If I cannot keep fluids down, I call my doctor before I take my blood pressure pill. That sentence could prevent a fall. It could prevent a hospital admission. It is that important. The most dangerous blood pressure reading is not the highest number you have ever seen on your monitor. It is the one you took at the wrong moment and made a frightened decision from. Blood pressure is not a fixed number. It shifts constantly, with sleep and waking, with caffeine, with stress, with posture, with the simple anxiety of having just worried about your blood pressure and then immediately sitting down to check it. A single reading at the wrong moment is not a verdict on your health or your medication. I think of a woman I will call Diane. She was checking her blood pressure multiple times a day, every time she felt anxious, filling page after page of a notebook with numbers that terrified her. She was convinced her medication had stopped working. When we slowed the process down, same arm, same chair, 5 minutes of seated rest before checking, and looked at the pattern rather than any individual reading, the picture was completely different. Her medication was working. The chaos was in the method, not the medicine. Measure at the same time each day, same arm, same chair, 5 minutes of calm rest before you check. And when you look at your readings, look for the pattern across a week, not the number from this morning. One number is noise. A pattern is information. Only information deserves a decision. I have watched over many years 2 patients of similar age on identical medications at identical doses produce completely different results. And the explanation is almost never the medication itself. The medication is the same. The body it is working inside is not. High sodium intake means constant pressure building in the vessels your medication is trying to relax. Poor sleep raises stress hormones that tighten the very arteries your pill is working to open. Excess weight adds cardiovascular load that no medication fully compensates for. Physical inactivity, even moderate inactivity over time, allows artery walls to stiffen in ways that make every medication work harder just to hold the same ground. When your medication and your internal environment are working in the same direction, the results are stable, often remarkable. When they are working against each other, doses tend to climb over time, not because the medication is failing, but because the system is fighting itself from two sides at once. The best results I have witnessed across my career were never medication alone. They were medication plus an environment that gave the medication a genuine chance to do its job. And now we reach the 9th point. The one I saved. In all the years I have spent in cardiovascular medicine and patient education, the single most important truth about these 3 medications is also the one almost never spoken on the day the prescription is written. None of these medications erases the condition producing your high blood pressure. Amlodipine reduces how tightly your artery walls contract. It does not remove the stiffness that built in those walls over decades. Lisinopril blocks the enzyme that produces the tightening signal. It does not repair the vascular changes that cause those signals to fire too frequently in the first place. Losartan locks the door the signal needs to enter. But the signal is still being sent. All 3 medications manage the output of the system. They do not erase the system producing that output. This is not a criticism of these medications. They are genuinely effective, genuinely important, and for many people, genuinely life-extending. But understanding this distinction changes how you approach everything that comes after the prescription. This is why follow-up matters more than the first visit. This is why lifestyle choices are not optional extras once you are on medication. This is why a perfect reading on your monitor does not mean the conversation is over. The patients who do best, the ones I have watched manage their cardiovascular health with real stability and confidence over many years, are not the ones on the most medications. They are the ones who understood what their medication was doing and what it was not doing, and who chose to actively work with both truths at the same time. Let me bring everything together in a simple framework you can keep. If you take amlodipine, watch for ankle or foot swelling, particularly if it is worse by evening and better overnight. Notice any dizziness when you stand up too quickly. Report these things. Do not quietly manage them by adjusting your doses. Never skip doses out of embarrassment. If you take lisinopril, watch for a dry, persistent cough, even if it begins weeks or months after starting the medication. If you experience any swelling of the lips, tongue, face, or throat, especially with difficulty swallowing or breathing, get emergency care immediately. Do not wait. If you take Losartan, read every label on heart-healthy or low-sodium products in your kitchen. Watch for muscle weakness, cramping, or an irregular heartbeat. Ask your doctor when your potassium level was last checked. For all 3 medications, do not use ibuprofen or naproxen regularly without discussing it with your doctor or pharmacist. If illness causes significant fluid loss, call before taking your next dose. Measure your blood pressure consistently, not reactively. Never stop any of these medications suddenly without speaking to your doctor first. These are not complicated guidelines, but they are the ones that, when someone actually knows them, prevent the situations that feel sudden and frightening. Let me tell you what happened to Arthur. After I understood what had been happening, we adjusted his dose, reviewed his diet, and I sat with him, not with his chart, but with him, and explained everything I have shared with you today. He learned why his ankles were swelling. He learned, with real relief, that it was not his heart. Within 3 weeks, the swelling was managed. His blood pressure was stable, and Arthur was back in his pew on Sunday morning. He told me at his follow-up, "I spent 3 months convinced I was dying from something that had a name and a simple answer. I just needed someone to explain it." 6 months later, he brought a 1-page summary of what he had learned to his Sunday group and handed it to 23 men. 5 of them went to their doctors with questions they had never thought to ask. 2 received medication adjustments that were long overdue. 1 had been writing off dizziness from Amlodipine as simply getting older for 7 months. The information existed. The solutions existed. The conversation simply had not happened yet. That is exactly what this channel exists to do. Now, I want to ask you one question before you close this video. Which of these 3 medications are you currently taking? Amlodipine, Losartan, or Lisinopril? Just type the name in the comments below. That single answer tells me what matters most to you and helps me decide what I cover next. And carry this question with you before your next blood pressure reading. Do I actually understand what my medication is doing inside my body right now and what it is not doing? If the answer is not fully yes, that is not your fault. That is the gap this channel exists to close. If this video gave you something useful today, please like it and share it with someone you care about who is managing their blood pressure. Subscribe so you do not miss what comes next. I publish every week for people who want honest, clear guidance about what is actually happening inside their bodies. I am Dr. David Aid. Take good care of yourself, and I will see you in the next one.